to, I'm not sure which one this is, but it must be about number 6 or number 7 of the GECCO meetings. Again, it's nice to see a crowd. We've got 30 or so, and hopefully another 20 or so coming to join us. This week, we're going to talk about 2 things. We're going to talk about the practicalities of endotherapy for non-variceal GI bleeding. And we've certainly got our Cape Town expert to keep you up to date with that. And she's a very practical lady. She's called Galya Chinnery. And she runs the foregut service here and has a special interest in upper GI bleeding and endoscopic interventions. Then after, we'll take question time around her, and Ed Jonas will handle that. And then he has to introduce me, and I will give a talk, again, a case-based talk in this case, around liver abscesses. So I hope you enjoy the offering, and I'll hand over to Galya, who will set up her screen sharing and take over. Thanks.
Right, can you hear me now?
Yes, we can.
Thank you. So thanks for joining. I've been tasked with giving you a practical approach to non-variceal upper GI bleeds. And I must make a disclosure in that this is entirely my own. Can you hear me now again? Sorry,
Yes.
I got.
Yes,
Okay, I got.
Carry on.
Okay, so this is entirely my opinion. So those of you that do a lot of GI work will have better ideas than me, perhaps. So please share them at the end. But for all intents and purposes, let's stick to a very practical talk for this 17 minutes that Prof's given me. After that, he's going to mute me. So I thought we'd start off with a case that we had on Sunday. A 67-year-old male, heavy smoker, COPD, peripheral vascular disease, chronic NSAID abuse, and admitted after an upper GI bleed with an HP of 6, classic kind of patient. So to start off, I think, you know, the whole thing about whether you should be using the various scoring systems that are available to help triage your patients, I think that's up to you. I think they're very useful in that they predict mortality and rebleeding risk, obviously. And which one you use should be something you're comfortable with. I think each have pros and cons. Glasgow-Blatchford is probably the most, you know, well-known and predicts fairly well which way it's going to go. Rockall's score has the disadvantage in that you do need an endoscopic evaluation to determine the full score. And the AIM65 is pretty easy to use, but probably not the most sensitive. So for all intents and purposes, I think it's a practical thing. You need to decide. We have made an upper GI hemostasis box. We've got everything we could possibly use in a bleeding situation in this box. And we run off wherever we're going with that every time. So we know everything's there. So that is something very useful. I can recommend doing that. As regards your management, I think I'd only like to mention one thing, in that you have often a patient really unstable, bleeding a lot. Please don't waste your time. Go and secure that airway so that you can do a safe scope. So general anesthesia can't be underestimated, the benefits. When to perform your emergency scope, as I said, you've got those triaging mechanisms, but for me, I just remember 2 things basically. Is my patient unstable after initial resuscitation, or was that patient presenting with a moderate to a large volume hematemesis? I'm going to do an emergency scope that same night. That's all I would remember. So this is the case in question. This is what we found. The initial endoscopist went down, found a large penetrating ulcer just below the incisura. I hope you can see that. Let me point it out that there, for those of you that can't see so well, that is a visible vessel. And that will make it at least a 2A according to the Forest classification. And as you will know from that, there is a considerable risk of a rebleed. So you'd best do something proper about it. Now, I think broadly speaking, definitive endoscopic therapy you can categorize as either mechanical or thermal, be that whatever way you go. For today's talk, we're not going to debate dual versus monotherapy. I think dual therapy is always the way to go. I think there's more than enough evidence for that. We won't talk about that. Back to our case, the primary endoscopist popped on a very nicely well-placed hemostatic clip and was quite happy with the result thereafter. And the patient went up to the ward. Not bleeding, obviously, at the time. Just a brief word about what type of clips you've got available to you. I think a couple of factors for me. I think we're all in a situation where cost is important, so that's something to consider. You'll see that type B, the clip in the middle, has got a really nice width as regards the open clip. So for me, the opening width is very important. Compare B to A. I think B is far more appropriate for most situations. The rotatability of your clip, I think these days, if you're purchasing a clip that doesn't rotate, you're losing out, and most manufacturers are going that route. You need to look at the strength of your tissue closure, obviously, and the ease of release of your clip. Some of the clips are quite sticky, and you have to fiddle them once you've shot it off to get it loose without pulling off your clip. So that's also not ideal. And some of them, which is really bad in my opinion, can only open and close once. So if you've misplaced it, you have to fire it. And I think that is also something you should never consider purchasing. So everyone's got their indication for a clip. I like a wide open clip that rotates and is easily released. So back to our case. Unfortunately, he rebled quite significantly to an HP of 5, and this was within the first 24 hours after his initial scope. And if you can see there, I'm not sure how well it projects, there's a large organizing clot hanging over the entire antrum and incisura area where we know this ulcer is sitting. Now, you may feel a little bit concerned or anxious about removing a clot. I think when you're starting off with scopes, it is a scary thing to do. However, I think it's an essential thing to do. I mean, he's had a massive bleed, and if you don't sort this out, it's just going to be continuous. So in this case, I would go for the biggest snare that I've got in my box. Try and snare as much of the clot as possible. Remember, the snare will cut through your clot. So ask your assistant to close carefully until you've got a bit of a grasp on something, and then you pull away. You do not need to pull the clot out of the mouth. That just becomes messy. You just place it in a different part of the stomach. And if you change the patient's position, the clot will stay there. So always have a snare in your box of goodies that you're going to carry around with you. Then the next step for me is always to inject, and you're going to dilute your adrenaline with saline and inject near or at the base of the bleeding site. And obviously you all know it works by tamponade and perhaps a bit of local vasospasm. I think for me to say you've injected and tamponaded with a volume of 5 mils, you're kidding yourself. You need a good volume. So I would always try and aim for at least 20 mils. The other thing, put out your needle before you actually inject. Because if you are finding a very easy injection, you've probably injected right through the wall of your stomach, and your tamponade is not going to do anything. So just here, what I'm trying to show you, we're back at the same spot now. There's the clip from the night before, and you'll see there's something going on here. So I advance my needle so that I can actually see the depth that I'm injecting. If you put your needle stump right there where you going to want to inject and then advance your needle, you may well go right through. Try and inject circumferentially, or at least in 4 quadrants, 3 to 5 millimeters away from where you think the bleeding is. It's kind of pointless to inject over there. You need to get to the base. The more difficult it is to inject, the more likely you are in the right place. Sorry for the background noise, but this is what happened after I injected, and I do hope you can appreciate there's a nice active arterial bleeder in that puddle of blood there. So I've obviously gone straight into the artery. So what now? Now, this Ovesco clip, I must be honest, has a really firm favorite spot in my box, in that certain situations it's absolutely fantastic. Specifically in patients where there is a quite firm fibrotic base, where if you keep trying to put on hemo clips, they keep scratching the surface and just falling off. The concept of it, for those of you that haven't worked with it, it gets applied very much like a normal variceal bander, pretty easy to put on. There's a few tips about that. We'll get to that. I do appreciate this is not something that every unit has, but I would properly advise you to at least have 1 or 2 boxes, even if it's just on consignment stock somewhere in the back cupboard. It's really useful on the odd occasion to have this. So this is the view. It's quite narrow, strict, narrowed view, obviously, much like a variceal bander. The big difference is this cap that you're putting on the tip of your scope is jolly wide. And you'll find that if you're doing this under just a bit of conscious sedation, you may well really struggle to get through the cricopharyngeal area. So either if it's safe, you're going to have to up the sedation, or ideally, you do need to have a general anesthetic to get this down, especially in the smaller patient and the younger patients. Also the old ladies who struggle to get through. Little tip here. If you look carefully, I hope you can see there's 3 little semi-lunar plastic little cusps. And if you do deploy these Ovescos, you will know that pushing the cap right down onto the base where your scope tip starts is absolutely essential. If you leave it too far hanging off, it becomes quite an unstable device, and you can actually just lose that whole thing quite easily. And it's quite an expensive thing. I stand corrected, but I think it's about 5,500 Rand for 1 clip. So it's really worthwhile putting that thing on properly and doing a good job the first time. The way it works is you pop it on the area that you want, and you start applying suction as constantly as possible. Don't let go. And if you're happy, there's a little wheel that turns the string and fires off this bear clip shaped clip on the bottom. It's got enormous tensile strength, and it will go through anything, no matter how fibrotic. It's really useful. So that's what we did here. I'm not sure if you can see, there's the base of one of the sides of the bear clip, the Ovesco clip, and it's got that artery quite nicely, but we had a bit of oozing in that area, and we popped on 2 extra clips, and 1 clip was misfired, unfortunately. So if you're looking at the base of this, this is about 10,000 Rand sitting there. But you've avoided ICU, you've avoided a laparotomy in a patient that probably wouldn't do very well at all. Different scenario. This, I hope you can see, it's a little bit dark, but hopefully you can appreciate a very brisk arterial bleed right on the top of your screens. And this is actually a Delafoy. And I think from this is probably one of the first ones I saw actively bleeding like this, and made me really appreciate the intensity of the bleed that they can present with. So interesting situation. What actually is it? This is just my little sketch. This is the way I understand it. It's a large tortuous artery, which you must imagine running parallel to the mucosa. You may see it like we did there, with a nice juicy active bleed, or alternatively a small little clot. And what's distinctive is that you do not have an ulcer in that same area. Where do you find these things? Actually, anywhere in the GI. Obviously, the vast majority we'll find in the stomach, but we do find every now and then 1 or 2 in the duodenum, and they can be quite spectacular in their bleeding. I've not personally seen one in the esophagus, but I do believe they occur there too. What do you do about them? Well, there isn't really much agreement on them, so I'm just going to give you my opinion. And I do think you have to bend the rules a bit as to where is your Delafoy's. Some of them are jolly difficult to access. And you also have to decide what are you able to do comfortably yourself. Regardless, endoscopic management is the way to go. You do not want to operate this type of patient unnecessarily. So what can you do? You can approach it with a thermal instrument of whatever kind. You can coag it with a gold probe or with argon. That would not be my first choice, in that I'm just basically putting a clot on top of it. I don't think that's the best idea. You could inject it, tamponade the thing, or if you have some sclerotherapy agent, you could do that. Also not my first choice. I would definitely go with a mechanical type of solution here. I think you can band them. Same bander that you pop on a varices, you would go close to that thing. It fits beautifully into the cap, suck it up, pop on a band, and you're sorted. Alternatively, you can put on some hemoclips. Most of the time you'll find you'll use a couple. And mechanical solutions for Delafoy's works the best. And here you see we've used another Ovesco clip, and there's a little artery sticking out there. So that worked nicely too. Mallory vice is another situation that can occur quite frequently for us. You'll see here, sorry for the noise. Let me pause it there. There's a little tear there just at the OG junction, which is not bleeding. And that's, to be honest, what we see most of the time. So usually you can leave it alone. If, however, as in the middle picture, you see a little bit of ooze and you're a bit worried, there's constant bleeding there, do sort it out. But again, I'm going to suggest to you, in my opinion, I would use clips. In that, for those of you that have done esophageal myotomies, you'll know that diathermy splits esophageal muscle beautifully. Goes so easy, like butter through that. And in my opinion, to start fiddling in an area where there's just muscle, you might just perforate that. So I'd be a bit scared, but that's just me. I would use clips if it is definitely still a problem with oozing or bleeding. The other thing that you'll find every now and then is the peptic ulcer with a really nasty fibrotic base, where you can clip yourself into a very nasty situation. You can scratch that surface. Here you'll see a large ulceration, which is actually almost definitely eroded through onto the liver surface, and then 2 little spots that we're concerned about. In that situation, please don't go and put clips there. I think this is a good situation for a gold probe coagulation. Remember that you do need to apply it for some length of time, but if you do it too long, you pull back your gold probe and you actually pull off a whole big clot of coagulated tissue, and then you rebleed. So it's a bit of a balance, which is sometimes a bit tricky to figure out. These are not my pictures, but demonstrate quite nicely what's something in that you burn in one spot, don't move around. If you see the vessel, burn directly onto that, and then you get this beautiful donut-shaped sort of whitish appearance of the tissue that's been coagulated, and that's a really nice result on that image. Here's another situation where you have a nice visible vessel. What can you do with that? I think this situation, there's a couple of things. You definitely should inject first, just so that if you misfire or you do get some bleeding, at least there's some tamponade behind it. You can pop on an Ovesco clip. You can pop on hemoclips here. You could probably gold probe this. I think this might work as well. Might give a bit of bleeding, but I would probably go with mechanical. And this is what we did. We put clips on, and that's a day or so later. The other thing you can use when you've got a visible vessel is a coag grasper, which nicely grabs the vessel, and then you can really burn it quite effectively. But I think this is a bit of an overkill in that you have other instruments that can do the same job, and these things are not cheap. They're really quite expensive, and I would keep them for endoscopic resections rather. And if you do use it on a short stump and you burn away and then suddenly starts bleeding, you can't use that instrument again. So if you're thinking of burning something and the instrument needs to be closed, don't use this. You're just wasting the whole thing. Use a gold probe. The other situation that you and I will see quite often is gastric gave. This situation is quite diffuse, you'll see here. What do you do about that? I think most of us, our first thing that we grab is an APC probe. Only one tip, this is not my image, this is off the internet, but it shows it beautifully in that your probe must not be touching the mucosa. Then you just tear off and it gets stuck. Be it 1 or 2 millimeters off and then it works beautifully. But don't be too close, that's the one thing. And that's your end result, spots all over the show, but a good result. Alternatively, if you have 1 or 2 very localized areas, you can put bands over these gave areas. It works really nicely as well. And you'll see here a couple have been put on. The bands you use are the same as the routine banders for varices. The other thing we've used, if you have this in your unit, those of you that use the Barracks system for radiofrequency ablation of Barrett's in the esophagus, you can use this on a nice watermelon stomach where you've got a whole big patch to burn. This one that I quite like is through the scope paddle, and then you just apply your pressure points to wherever you see. I don't know if you can see there's slightly white areas where burns where the radiofrequency ablation has been applied. That works quite nicely. I don't like using the balloon in this area. I think it's pointless and it's wasting a lot of money in that the stomach is so big, you can't get the pressure you need with a balloon in the stomach. So don't do that. I would always use this little through the scope paddle. I think that works best. The other thing, a small gist, you can obviously find that as a bleeding source every now and then. While I appreciate that this is not the case often, every now and then, if it's a small bleeder, you can pop on a over the scope clip over that quite nicely, and that just gives you time to work the patient up, CT scan, and not rush to theatre for an urgent scope. The last slide I have for you is just my opinion on hemostatic powders. I think they're not top of my list, to be honest. I think they're useful in situations where there's much diffuse bleeding and you can't actually localize the point of bleed, or if you really can't see anything. And I think for me, the only time I would really consider this is in a gastric carcinoma, where the tissue is just diffusely bleeding and you can't actually burn or clip anything with much effect. Remember that your powder doesn't stay there for very long, and all of these big ulcers, you shouldn't be just putting on hemostatic powder. It's a temporary thing. It just creates a false sense of security, I think. It makes a little shell over it. There's a clot underneath. It'll just bleed again. So I think this should be potentially, in my opinion, of course, reserved for a situation where you want to transfer a patient to a unit where a second look definitive endoscopy can be performed. I don't think this should be a primary monotherapy. So yeah, there's a couple of situations where my opinion, obviously, I think there's other ways to do things, and hopefully some of you will be able to share that with me. Thank you.
Thank you very much, Galya, for this excellent talk. There are 2 questions posted that I'm just going to read. From Wisdom, why did the endoscopist use injection of epinephrine plus a clip given the evidence? And then in the same question, was there no concern for malignant edges, and is there no need to use NBI?
So as to the first part, in my unit, will always tell my colleagues to inject first. I think there is the situation that you really don't want, where you misfire your clip, or you actually scratch the surface, or you dislodge a clot to such a point that you really have an active bleeder afterwards. So I'm quite in favor of putting a tamponading effect first, and then sorting it out with definitive treatment. That's just what we do. If you are happy going straight for your clips, by all means, please do so. The ulcer edges regarding malignancy in a gastric ulcer like this, I'm not concerned with right now. This guy is having an active bleed, and we'll sort that out. To me, this is quite a benign looking ulcer. We will definitely bring our gastric ulcers back for a routine follow-up scope at 6 weeks, and then we should biopsy them. I do agree, but I think this one is benign. We don't bring our duodenal ulcers back routinely.
Okay, and then just a second question there. What do you think about covering this patient with antibiotics? And Ceftriaxone IV is mentioned. And what about eradication of H. pylori in this case? I think it refers to that.
Yeah, thanks. I would not give IV antibiotics. I don't think that's necessary. And we routinely do not. We will discharge this patient on double dose PPIs and eradication therapy routinely. Yeah.
Right. Then I just have one or two questions, Galya, if there are no more posted. You mentioned you use adrenaline to inject. What about things like Tacil or tissue expanders? Don't they work better?
Maybe they do. I don't know. I know you've also had thoughts of using other things. I have some tissue expander that's been given to us. We've also got new things from the reps. It's at 500 Rand for 5 mils. So it's a cost thing, and it's just an ease of access. And I think whatever you're using, it's a temporary thing, and I need it right now. So we're going to go with what's cheap and available.
Okay. And then just sort of a practical thing. So when you get into a stomach with massive clots and you can see there's active bleeding going on and you have to get rid of the clots, any tips there? Do you believe in erythromycin?
I think there's some evidence for that. But to be honest, I think we usually forget to do that when you're rushing the patient to theatre. If you've got time to do it, I don't think it does any harm to give a dose of IV erythromycin. We don't routinely do it, I'll be honest. Yeah.
And I see there's a question from Sandy about Ovesco in the duodenum. Is it safe?
Yeah, not so much as it's safe. May I just ask? I think you can hear me.
Yes.
Obviously, you've got room to deploy Ovescos in the stomach when you've got good control of the instrument, but often in the duodenum, there's a space issue, especially if it's a big ulcer or a dual ulcer.
Yeah.
Have you got any tips, or do you like using the Ovesco in the duodenum?
I do definitely hear you, and I agree with you completely. It is a space issue. I think even with a clip, it's a space issue in the duodenum. It's a nasty place, those posterior ulcers, especially if they're deep. So no, I don't think it's always going to work, for sure. The other place that I find difficult is if you've got an ulcer in a hiatus hernia. That can also be tricky, that angulation. Would I have concerns about putting it there? Not really. I would probably do it. I'd be very careful of the lateral wall close to the ampulla. But that's not obviously a place where you get ulcers often. I would put them in the duodenum if the angle is good. The one spot where I wouldn't, there are people that advocate putting Ovescos for mallory vice tears. That I think is overkill. And to have a foreign body indefinitely in your esophageal area, to me, that doesn't work for me. So there, no. But in the duodenum, if I can get there, I will do it.
Yeah, I also share the duodenum as a tricky area, and I think sometimes the heater probe or the gold probe are very useful. And the other thing is, do you ever use irrigation pumps to try and get things clear so you can actually see what you're doing? And do you?
No, I use the 60 ml syringe. I find the irrigation pump, you don't get as much force. I just find the pump, the syringe a bit better. But again, if you're not winning with that, you have to grab a snare. and snare that clot off. I think that's where people just keep irrigating. You need to snare it and sort it out, whatever's underneath.
Okay, Galya, I think there's one last question here from Dirkie Klaassen about where the best place is to do these cases, in theatre or in front room emergency unit.
You know, the really unstable patient needs to go to theatre. There's no doubt in that. If you can't control it, you need to go and do something straight away. So yes, I would always, in that situation, opt for theatre. I also do not underestimate ever the concerns of aspiration. I mean, most of these patients are a little bit frail, comorbidities, a bit elderly. You give them some sedation, they aspirate. So I think if there's a significant bleed, I would always advocate for an endotracheal tube. And if that's not possible anywhere but theatre, well, then it's going to have to be in theatre.
Okay, and then I think Lars also raised his hand if he has a question.
Well, yeah, just some input. Very nice talk, very nice illustrations as well. Two things. You talked about dual therapy, and I was wondering, obviously injection alone is not a good plan, but if you have the imaging to place clips, do you still want to inject first, or do you think that sometimes makes the visualization more difficult? And the other thing is, you did not mention interventional radiology. I think particularly for difficult duodenal ulcers with a rebleed, that should probably be considered as opposed to trying again with your scope, but maybe you have other experience with that.
Yes, I definitely agree with the interventional radiology, but from my talk, I was assuming we were going to be successful. But yes, specifically, I agree. For the duodenal ones, yeah, rather go there sooner than later if you're struggling, definitely. As regards the first part of your question, injecting before you put clips on, I think for the Ovesco, if I'm happy, I would not inject first, and generally we don't. But for the hemo clips, I appreciate that injecting sometimes actually distorts to the point that you can't see the artery anymore. So I think you have to balance that a little bit in certain situations. But I'll be honest, maybe it was just me not putting it on the right place, but I've had such bad experience in putting or clip slipping or just biting the wrong spot, and then you create a fairly stable situation into a 1A. So I'm quite in favor of injecting a little bit, to be honest, yes.
Mm-hmm.
Okay, if no more questions, thank you very much, Galya, for an excellent talk. And a pleasure to introduce Sandy Thompson. For those of you who do not know him, he's sort of a hybrid. He's a trained surgeon, but he was the head of the Department of Medical Gastroenterology here at University of Cape Town for many years. And he's going to talk to us about liver abscesses. Thanks, Sandy.
Thanks very much, Ed. Let's hope the technology sort of works. Just let me know if you can see my slides. That would be good. Whoever's unmuted. Can you see me, or can you see my screen?
Yes, we can.
Oh, okay, good. Thanks. So I'm going to start by getting you to look at this CT scan. Like everything else, I'm not a radiologist, but obviously you start to learn about things in your domain. And I think everybody can see exactly what's going on here. And I just want to use this to introduce what I'm going to talk about, which may influence your answer to the question, but you should keep it in mind when you see patients with space-occupying lesions in the liver. So if it's possible, it's a little bit tricky for me to run the poll, but I would like to ask you these questions. And if if Cheryl or Karen could just run the first poll about diagnosis. I'd like you to tell me what you thought that lesion was. And if you can just simply make your mark, and we will see what you show. I think we could just end the poll in about 5 seconds or so. I think we've got a good idea. I think we can, that's good. And you can see that most of you felt that this was indeed a pyogenic liver abscess. I don't think this would work well in an MCQ to decide your future, because obviously I've introduced complete bias into the question before we started. But there are a few people there who would consider other diagnoses, particularly that are familiar in our neck of the woods, which is HCC. However, if you notice carefully, there's no evidence of cirrhosis on the CT scan, which probably makes that a little bit less likely. So I'm going to close the poll and going to start with my talk, which is really going to be case-based about pyogenic and amoebic liver abscesses. And I've specifically included amoebic because obviously as you go up into Middle Africa or Sub-Saharan Africa, amoebiasis remains a problem, and it remains a problem in South Africa too. And we occasionally do see it in Cape Town, but in my old haunt in KwaZulu-Natal, it's actually the home of amoebic research for actually the whole of Africa. So this is a 54-year-old African male, and this was his history. He had a 6-kilogram weight loss, anorexia, malaise. He had some shoulder tip pain. He'd had severe toothache a few days, in fact, a week or so before he came, but it subsided without any problem. And the whole sort of history was over about 6 weeks. He was a type 2 diabetic, but was on insulin therapy. And he was actually a local politician in the provincial legislature. So obviously there was a bit of hype about him if you have to deal with these individuals. And on examination, he was, as you see, pretty okay. His blood pressure was a little bit high, but probably not much to write home about. And again, he did have a rotten molar, but he didn't look as though he had an abscess at all. His cardiovascular system was normal. And in the chest x-ray, which I'll show you in a little minute, he was said to have a small right pleural effusion. And he had an 8-centimeter firm, non-tender hepatomegaly, no bruit or splenomegaly. These were his findings. He was a bit anemic. His white cell count was raised at 20,000. His UNE was normal, as was his blood sugar was pretty good. And you can see that his liver function tests, his albumin was 27, whatever that might mean, but it's certainly not glaringly abnormal, but neither glaringly normal. And he obviously had some derangements of his ALK-Phos, his ALT, and gamma GT and AST. So there was something brewing in the liver. And he had these blood tests done. He had amoebic serology. Somebody in the physician line decided to do his prostate-specific antigen. I'm not quite sure what the significance of that was. And as you can see, his AFP, CEA, CRP, and ESR, where his ESR and CRP were the only real abnormalities that he had. And we screened him for HPV, HCV, and HIV, and all were negative, because obviously that might have a bearing on the etiology. this was his radiology, and you can see that that costophrenic angle on the right is a little bit obscure, but he doesn't have what we would call a surgically detected huge effusion. But for the physicians, that is definitely abnormal. And as Ed said, I'm a sort of hybrid. So I like to consider myself a surgeon who thinks like a physician occasionally. And this was the ultrasound, which showed this multiple hypoechoic mass with internal echoes in the right lobe. And they indeed queried the diagnosis of abscess. But the thing was, this chap looked perfectly well. We thought, he should be having rigors, being generally almost in septic shock with an abscess that was of this size. And obviously it looked rather irregular to us, even having a good look at the CT in all phases. So this was his CT that I showed you first up. And again, not a lot of enhancement, and I can't show you all the phases for a few things, but we did entertain that this might be a malignancy of some sort in the liver, even a lymphoma, because it just was, he was so well, apart from the raised white count, but obviously signs of chronic illness, and we weren't quite sure what was going on. We did get his dental caries sorted out, and again, these were the sort of pluses and minuses for it being a malignant lesion, even an odd one, or a liver abscess. So these were, again, as I said, we've discussed this differential diagnosis, and maybe it was some funny tumor that you occasionally see in the liver. But obviously, one of the things that you can do is, obviously, we were doing background checks. We did obviously blood cultures, which were negative during the first phases of his illness. And then this is what transpired. You can see obviously that this thing is evolving and that we need to do something about it. And now it looks much more like abscess to most people. So we decided that we would go and do a laparoscopy with a view to draining it. We was put on empiric antibiotics, including metronidazole, because even despite his negative amoebic gel diffusion test, the physicians were very cautious. And these were the drugs that we put him on. And obviously, this is really what happened in real time. And I was on the fringes of it to start with, and suggested that they drain it laparoscopically or just have a good look at it to see if there was underlying liver disease associated with it that we hadn't detected because of his enzymes. And then we decided to have a look, and it was obvious that there was pus draining from the biopsy site. And we put a Portavac drain, rather a small one. Again, I wasn't in theatre at the time, but that's what was done. And obviously there was minimal pus draining from it. So we continued, and we definitely obviously knew at this stage that this was a liver abscess. And we continued his antibiotics, but unfortunately, he remained actually amazingly well, and his white cell came down, but we'd obviously only taken the lid off this thing. And again, there were no bugs to be found, which is not surprising. But then we did actually realize that he needed to have this drained. And we did it good old straightforwardly through the liver into this collection. Unfortunately, didn't infect the pleural space. So that was this gentleman who posed a diagnostic dilemma for us because he was so well, and we were entertaining a non-benign diagnosis. Eventually we got there, and he did very well, and we sorted out his teeth, and I'll come back to that in a little while. Then there was another case. This was also, in fact, this was a leading national politician's wife, and the physicians in their wisdom decided to do a gel foam liver biopsy for a patient who had infiltrative liver function tests and was said to have had episodes of febrile cholangitis, but I'm not quite sure what that meant. Anyway, to cut a long story short, she presented 2 weeks after this biopsy, which unfortunately failed to reveal any infiltrative disease or help them to manage the patient, with rigors and right upper quadrant pain. And the ultrasound showed a 4 centimeter heterogeneous lesion somewhere in about segment 4. So I'm going to ask you another question now, and that is, what would you do with this? It's about 3 to 4 centimeters on ultrasound. It hasn't had cross-sectional imaging. And perhaps we could run the next poll and just see what the audience comes up with here. So she's had a gel foam true cut biopsy, and 2 weeks later she comes back febrile with obviously a collection in the liver. So please feel free to vote. So you want to aspirate and antimicrobials. Again, you can see how different people think about things. At this stage, she was firmly in the hands of, yeah, okay. Maybe there's a few physicians amongst you. So could we end the poll and share the poll, please? And you can see there that most people want to aspirate and use antimicrobials. But let me tell you what actually did. And there are a few of you there, not very many, who had opted for antimicrobials. And I think that this lady wasn't diabetic, but again, you can argue about which antimicrobial you could use, but hopefully it is a skin organism. So we'll leave it there and move on to what actually happened with this lady. So she, 2 weeks later, after not being aspirated, she returned. Again, she was actually quite well. So it shows you how you can defervesce the systemic inflammatory response. But there's no doubt that, and again, it's reasonable not to aspirate something that's 3 centimeters in diameter. But obviously, this thing was getting slightly bigger. It was now over 5 centimeters in maximum diameter. And indeed, she had it aspirated. And again, there was 10 mils of pus. That was all that comes out. And the needle was removed. Again, you could argue whether or not you should put a pigtail into it. But they felt aspirating to dryness was okay. And they cultured anaerobic organisms, interestingly enough. But again, with 6 weeks of treatment, she had a marked clinical improvement clinically, and this was confirmed with her ultrasound. So you can see that you should think twice before you biopsy the liver, because there is the odd risk. And of course, the other risks when you do interventions into the liver for biliary access also have these same risks associated with them. The third case is what one would consider more straightforward, a 45-year-old female with right upper quadrant fever and rigors. And she, again, was jaundiced to the surgical eye. So that means her bilirubin was at least over 70. And she had right upper quadrant tenderness. And this individual had multiple cystic lesions in the liver at presentation, and a stone in the gallbladder, or at least it was thought there were stones in the gallbladder on ultrasound, but they weren't entirely sure. She did not have biliary dilatation, obviously, and the common bile duct was not visualized, which is not uncommon in the situation that we find here. And this was her liver when she had a scan. And that was because the ultrasound found these lesions in the liver. Here you can see a solitary stone in the gallbladder. At least that's what was construed as. So she was fairly straightforward. And here you can see the dilated bile duct. So we were starting to feel fairly convinced that there must be something down at the bottom of this causing her problem. And the papillotomy was done, and indeed there was a large stone which was extracted, and there was some pus above it. And the lady was put on intravenous antibiotics. and we let her defervesce. Her gallbladder, in fact, wasn't hot. It was non-tender when the whole thing defervesced. And we left her on antimicrobials on the grounds that these were not micro abscesses, but multiple abscesses in the liver. So I think these three cases illustrate the three sort of typical presentations that you can think about in relationship to liver abscesses. And I'm just going to say briefly a few general remarks about pyogenic liver abscesses. They account for 75% of liver abscesses in developed countries. In developing countries, especially in Africa and sub-Saharan Africa, amoebic are actually more common. And that may be partly due to several factors related to healthcare. The most common secondary intra-abdominal infection, believe it or not. 15% are cryptogenic, and I'll come back to that. 15% are associated with diabetes. And beware in the elderly, because like this gentleman that we had, they're often insidious and they present with a pyrexia or subtle signs of inflammatory markers that are often not missed because the clinical picture is that of less severe disease. So you should think about them in these territories. We haven't, so I throwed you three examples of iatrogenic, of biliary tract, and of the obvious hepatic artery, because we presumed that this was a systemic infection that had seeded itself into the liver. The worst kind that you can get actually are the portal vein ones. And the portal vein hepatic abscesses are associated with infection. But even worse, they're associated with small thrombi that get into the liver. And not only do you have an infected source, but you have areas of compromised vasculature to the segment of the liver. So it makes treatment quite difficult and often unsatisfactory. So portal vein ones are, again, usually small, but often associated with intractability. And then, of course, if you can't find anything else, these must be cryptogenic. So one of the messages you really should think about is that if you see a patient with suspected liver abscess, with tenderness in the right upper quadrant, with fever, then you should actually do blood cultures early on, because they will give you a very good clue as to whether this is enteric, biliary, or whether it might be from systemic infection. And so I can't emphasize more that before you start antimicrobials in these patients, before you start them, and unfortunately that may have already been done, you want to try and find out what's going on. And again, if you're planning to aspirate them, then again, you want to try very hard to see if you can get a culture or a gram stain from these to help you direct your therapy. So I've said enough about pyogenic liver abscesses. I now want to just move on to talk about amoebic liver abscess. And again, this is a 50-year-old female. Again, note she's a female with abdominal discomfort, mildly tender hepatomegaly, and she had no response to metronidazole. But she had a positive amoebic gel diffusion test. This was quite a few years ago, and the amoebic gel diffusion test now has been replaced by an ELISA serology, which is probably a much better test. But the amoebic gel diffusion test was very valuable, as I will come to again. So the question is, you can see these lesions, again, mildly tender, and this is indeed what are the clinical relevant issues in relation to this lady. Is it amoebic? Is it pyogenic? What medication should we start her on? And when should we aspirate in conjunction with medication? So there is quite a bit of information emanating from Durban and also from other areas where amoebiasis is endemic. And when I first came here in 1986, I was involved with Delaray Nell and subsequently involved with a plastic surgeon called Magar, And we've published on these, and I'll show you some of that evidence. That was back in 2003. But the bottom line is that amoebic liver abscesses are getting less common. They're still relatively frequently seen in endemic areas. And again, we probably see 3 or 4 a year in Cape Town, and maybe Ed can update us as to how many he's seen since he moved here a few years ago. And again, there's probably lots of reasons for that. And in fact, amoebic colitis is also rarely seen as a serious illness that requires hospitalization now, probably because improved sanitation, but also because of the liberal use of metronidazole, for which it still is effective treatment. And again, there's obviously a much better awareness, hopefully because the messages got through at district and primary level of care to manage these patients with diarrhea and dysentery in an appropriate antimicrobial manner up front. And that negates this untreated severe illness that we used to see when I first came here in 1986. Again, it tends to be a male disease. It's very, very tender. They have percussion tenderness over the liver. They're usually big when you see them. And they're usually chronically ill as well as acutely ill. And I think that's part of the reason that they don't manifest this huge systemic inflammatory response. They do respond to metronidazole. And it's very unusual that they are not amoebic gel positive. So you must bear that in mind, that most of this work was coming before AIDS, where HIV was a major consideration. Again, pyogenic patients tend to be older. They often have comorbidities, especially diabetes. And again, they can have multiple abscesses. They usually have low amoebic serology or completely negative. And again, you want to obviously look for sources in the abdomen, depending on the age of the patient and whether or not there might be systemic infection in the teeth or in the heart valves. Again, heart valves are something that we should think about in the South African context because of the high incidence still of rheumatic fever valvular disease. So is this amoebic or is it pyogenic? And again, if you see a lot of these, you can make the diagnosis. It's like if you have endemic schistosomiasis, you can see them on ultrasound alone. And here you can see this characteristic rim. But of course, they do occur at all phases. And it is actually a liquefactive necrosis. It is not an infection. And so depending on where it is in its degree of liquefaction is what you will get as an appearance and what you will get out of it. And classically, what you get out of it is anchovy sauce. That's the classical thing. It is a sterile abscess. And the only way it can get infected is if you introduce it in an iatrogenic manner. I was fortunate to work with the late Professor Lavuno, and he was probably the man most versed in the practical treatment of amoebic liver abscess and amoebic colitis in the country. So you should read his readings if you're interested in finding out about etiopathogenesis of amoebic conditions. But then there is obviously the thing that, do you aspirate or procrastinate? And generally speaking, surprisingly, Mr. Lavuno was a procrastinator. He didn't believe in aspiration. And of course, that ran through the surgical department there. But however, you can see that there were individuals who were very scared of peritoneal rupture, rupture into the chest and into the pericardium. I've seen free peritoneal and chest rupture, but never pericardial rupture. And hence, the physicians advocated aspirating these bigger abscesses on the grounds that it would reduce the rupture rate and reduce the mortality. And there's some evidence that if you aspirate the small ones, you can manage them as outpatients. We were never ever brave enough to do that at King Edward. And the complications of ultrasound guided, again, it should be safe, it should have a minimal risk. And so the physicians say well, it's pretty safe to do it. Why not do it all the time? But I would urge you not, that's not necessary unless there are certain criteria. So what's controversial? They used to say that the left lobe abscess would rupture into the pericardium. It very rarely does, and usually they're ginormous. So again, if they're less than 5 centimeters, we really shouldn't be trying to treat them in that manner, even if there are several of them. And sometimes they do coalesce into bigger abscesses as the necrosis merges into one. And then you can aspirate all the abscesses that are greater than 10 centimeters. Again, large abscesses can be monitored. And if they're not symptomatic, we used to watch a considerable number of them. So there is consensus that if there's failure to clinically respond after 48 to 72 hours, after they've been on effective metronidazole treatment, that you might want to aspirate them. And of course, if a pyogenic abscess cannot be ruled out, that's an absolute indication to do it. And again, we relied heavily on whether the amoebic gel diffusion test was positive or negative. Again, that may not be such a reliable guide, but again, you can think of those things. Again, the take-home messages, the majority of ALAs need only metronidazole. Absolute criteria are not absolute, and close clinical monitoring is the way to go with most of these abscesses. Do not hesitate to aspirate, as it is pretty safe if you have a good indication. And the larger the abscess, more likely it will be that it will eventually be aspirated. I'd like just to leave it at that and hope that I've given you some insight into liver abscesses, and would be very interested to hear from people around Africa as to what they encounter and how whether these management principles are of use to them. Thank you.
Thank you very much, Sandy. There has been a couple of questions posted. I'll just start with the first one from Wisdom. What is the sensitivity and specificity for amoebic serology in the evaluation of liver abscesses?
I think, again, we used to use it as a rule out test. So if it was positive, we would believe that it was an amoebic liver abscess. So we would tend not to aspirate those. And that was, again, we were in a highly endemic area. So we would see probably 20 amoebic liver abscesses to every 1 pyogenic. So I think it is a very sensitive and specific test. Again, in people who are completely immune suppressed and in amoebic colitis, I don't think it's such a good test and can be misleading.
And just the second question there, also from Wisdom, because we all, even if we have CT there, we've got access problems. So his question is if ultrasound is good enough to make these diagnoses so that you do not need to perform CT, it may be challenging.
Yeah, again, I think if you come from areas that are seeing a lot of them, and I would be interested to see if it's still prevalent in Zimbabwe or whether its incidence is on the decline as well. I think as you go into Malawi and further up, it's still very, very common to see it. And again, that I think will influence the accuracy of being able to do things with ultrasound. Again, if you just see it sporadically, then I think you might want to have a lower incidence to aspirate it to see if it's actually got bugs in it, or rather than necrotic tissue, it's actually got other aspects in it. So I think it depends on how endemic it is and how frequently you're seeing it as to whether ultrasound would be good enough on its own. That's my own view on it. I'm not sure if Wisdom would like to speak to that.
Wisdom, do you have any comments on that?
No, Prof, I have no comment.
Okay, thanks so much. Listen, and then there's also a question from Dr. Sandy Mosenye. You can maybe just clarify for me, because I don't completely understand it. In liver abscess drainage, is there no fear for possible tissue collapse into the central necrotic area, especially large chronic abscesses?
I think, of course, some of these large abscesses, they actually liquefy and they're actually almost like serum. And we used to watch some of these big ones for a very long time. And so we were very scared to involute them. That was another reason for avoiding aspiration. I think, again, if you've got a pyogenic abscess or these very big abscesses, you do want to get them empty, and they will continue to produce output. So one way is to actually not just aspirate them, but to use drainage for them. And again, we were quite reluctant to use drainage because we believe that's a portal to get them infected and with necrotic tissue around. So we reserved drainage for the big abscesses that were pyogenic and tended to avoid it. In the peritoneal ruptures, we used to debride the liver to make the hole bigger because it's actually quite fibrous around where it's burst through. And so we used to take a bit of liver tissue away so that we could get free drainage and put a dirty, great big old-fashioned latex drain into it with side holes in it, just to allow it to collapse under its own thing. But there are well-recognized vascular complications from it. You can get false aneurysms, you can get hemophilia. And so they're not very common, once in a blue moon, and usually they occur after there's been intervention in my experience.
Oh, thanks.
So yeah, I think that's answered that.
And I think then finally, there's just a question from Lars Obakken as well. In amoebic abscesses, what response can we expect in 48 hours of treatment? And how quickly will the collection resolve?
So again, that depends on the size and where it is in its evolution. But if you're seeing it acutely, then we would like to see the systemic inflammatory response reduce. And we were very old-fashioned. We used to examine the patient, and we used to see whether the liver tenderness was resolving. We were quite concerned if it was progressing after 42 to 72 hours, 48 to 72 hours. So we managed them clinically in that respect. And again, then, especially if the amoebic gel diffusion test was negative, we would have a very low index to aspirate them in that circumstance, but only in that circumstance. I hope that answers that question.
Right, thanks. And I see Wisdom just posed another one, maybe the last one we can take, because we have to wrap up, and that is, what about the possibility of liver cysts on one of the CT scans that you presented, and how would one differentiate and words on pair? I don't know if that more relates to echinococcus there, with percutaneous aspiration, injection, and yeah.
I think if you think it's echinococcus, the approach is entirely different. And I think the majority of echinococcal abscesses don't present in this manner. They may have a bit of liver tenderness, but they don't tend to have a systemic inflammatory response at all. Again, I think Ed is looking closely at the ones we've been involved with in Cape Town over the years, and a significant number of them have HIV, but they tend not to present in this way, and they do have very characteristic findings in terms of membranes, multiple cysts. So they do look very typical on the CT scan, but maybe Ed could fill in on that. They really don't present like pyogenic or amoebic liver abscesses clinically.
No, they don't. But just interestingly, I think there is a CT image floating around here that we use in lectures of a had an echinococcus and a simple cyst in the same liver quite dramatically. I think we should wrap up. Just the last question, because I think it's very relevant, from Masolwa and Gwanasai. What about metronidazole allergies? What do we give then?
Oh, wow. I think I'm going to use my prerogative. I hope Mashiko is still here. But I think that there are some other imidazoles that you could use. I'm not sure if it's a sensitivity issue. And perhaps we can revert to the old therapies. Mashiko wrote a chapter on it for a book, so she would be probably better placed than me to answer that. possibly if she's still logged in. Forgive me fending it in your direction.
I can't see whether she's on. If she is, no, I don't think she's on anymore. So I think we have to wrap up. Just a reminder as well to everybody that you can click the link that is in the chat box there to share your feedback for the session. We're always open for any suggestions, topics, and we've also had 2 sessions ago an interesting case from Onasai Shiaka that I think that was also very good and lively discussion. So if there are any interesting cases with learning points that you can share with us, feel free to do so. You can mail any one of us or make contact with Karen Fenton that usually send the announcements out. And again, just to thank Karen and Cheryl for the hard work they do to get these sessions going, and also for the colleagues in India that join every time and make sure that things work well, and it really worked very well today. I don't know, Sandy, any final comments from you or Chris Cassidy, if he's on?
We will have one more of these for endoscopy GI in December, and at that we will be hearing from GI units in Zimbabwe and in Tanzania about the problems that they have with running a service. We're very interested to know these things. We're also interested to know the relevance of the talks that we're giving and how they would help you in your own environment. So we really do appreciate the feedback, and we very much look forward to having you before Christmas on December, I think the 8th it is, where we will be discussing that. And obviously we'll have another case-based presentation. And certainly in the new year, I would like to echo what Ed has said about you providing us with cases that we can comment on from our side and try and help you to manage. So thanks very much, and thanks to Ed and to Galya for keeping things together, and we look forward to seeing you again. Thanks very much. Bye for just now.
Thanks.